Okay. And since we are talking about constrictive pericarditis, let's finish up pericarditis also. I hope you guys are alive, okay? Few minutes more. Or dead? Alive or not?
Still
Yeah.
here, still alive.
Great. Sorry. Few more days. We all will be, I mean, you guys will be done with the exam. Okay? Few more days. Come on. Okay, so pericarditis. What are the common causes that you know? Viral, good, great. Lot of questions on viral, so that always has to be there. A patient coming to you a few weeks ago had this runny nose and blah blah blah, and now coming to you with chest pain. Then what else?
Post MI.
Wow, superb. Cardiac causes. There are two cardiac causes. One is post MI, and other is Dresslers. Very good, Dresslers. Okay, here is the trick question. Okay, but let's finish the causes first. Then others. Come on, everyone think and tell me. Uremic.
Uremic,
Yeah.
yeah.
Then last will be like malignancy, surgery, trauma, radiation, blah blah blah. Important are these three. Okay. Now here the post MI one is important. Okay. Again, before that, what is a common management of pericarditis for all?
NSAIDs.
NSAIDs. Very good. With or without colchicine.
Mm.
Without, yeah,
Yeah, NSAIDs with or without colchicine. If it
colchicine.
is uremic, what is the level? What is the BUN level to qualify for uremic?
Is it like more than 50,
60. Okay, 60.
60? Okay,
Okay, this is high yield. Don't forget this. BUN more
okay.
than 60 with chest pain, then think of uremic as the cause. And the treatment for uremic is what?
Hemodialysis.
Very good. Hemodialysis. Super. Hemodialysis. All right. Then how is the this ECG of pericarditis?
So there
Uh,
is alternating QRS complexes, low voltage.
yes.
Very good. Diffuse ST segment elevation, first of all. This ECG is very easy because in the entire ECG, each and every lead will show you, like multiple leads basically will show you a lot of diffuse ST elevation. So easy ECG, diffuse ST elevation plus PR depression.
Depression.
Sorry, depression. Okay. And I think the one that you are talking about is electrical alternance, which will be seen in
Yeah.
pericardial effusion or tamponade, where
Mm.
there is
Okay.
fluid around the heart and then the heart will be like going back and forth,
Okay. Okay.
right? So that
Yeah.
is electrical alternance, but in cardiac tamponade. Here you will have diffuse ST elevation plus PR depression. Diffuse ST elevation is a giveaway for this one. All right. Coming to this thing that I wanted to mention is post MI complication. It is the name of this condition is peri-infarction pericarditis. Why this is important? Because you might mess up with the Dressler. Dressler is usually seen 1 to 6 weeks after MI. This is seen not in weeks. This is seen in less than equal to 4 days of MI. Okay, so number one, this is in weeks. This is in days. Peri-infarction pericarditis is nothing but a local inflammatory reaction. Okay, in that particular area, because of that delayed coronary reperfusion, all these inflammatory mediators were released in that area, which causes local inflammation. That is peri-infarction pericarditis within 4 days of MI. Diagnosis, UWorld question, but in cardio it's easy. The answer is always echo. That's UWorld, but easy. The treatment is tricky. You never give NSAIDs or colchicine in peri-infarction pericarditis. This one and this one are the exception to that normal medication. Here you give aspirin. That's UWorld.
Mm.
Okay, you do not give NSAIDs because of that prostaglandin, and some prostaglandin inhibits thromboxane A2. So basically, it is not helping in the healing process. So you don't give NSAIDs. Got it?
Yes.
Yeah.
Yes. Clear with pericarditis, everyone?
Yeah.
Yes.
All right. Okay. To pericarditis. Again, that is also very, very high yield. What are the causes, first of all?
Viral.
Viral, TB.
Very good. Viral. TB, very good. Superb. TB is very, very high. Some Asian patient would be given. Patient with coming from China, coming to you now with this all this pulses, paradoxes, fatigue, dyspnea, JV distension, all those things. Constrictive pericarditis. What
Mm-hmm.
else? One more important cause you have to remember.
Malignancy.
Something after malignancy, not malignancy.
Radiation exposure.
Radiation exposure.
Very
Yeah.
good. Radiation therapy. So most commonly they can give questions like this, that the patient had Hodgkin lymphoma 10 years ago, and because Hodgkin most commonly affects the chest, so chest radiotherapy was done, and now presents to you after a few years with constrictive pericarditis. Okay, so keep an eye for Hodgkin patients. All right, so radiation therapy is another high yield. Questions on all these three. Now, what is a giveaway for constrictive pericarditis? This thing, if you see on the chest X-ray, you don't need to look any further in the question.
Calcification.
Very good, superb.
Calcification.
Calcification. Okay, that's a giveaway. Don't read the entire question. If somewhere it is written there is pericardial calcification, directly look for the options. Constrictive pericarditis, go ahead. All right.
Yeah.
Okay.
Calcification only given in constrictive pericarditis and entire cardio. Pericarditis, right? Yesterday we did pericarditis. Yeah, we missed
Yeah.
was cardiac tamponade because we are talking about the same situations. So let's finish cardiac tamponade and then I'll start with the like completely new things. So cardiac tamponade. What is the classic triad that you guys know?
Hypotension.
Okay, very good. Decreased
Then
BP,
there is distant
Distended neck
sounds.
veins.
distended neck veins or JV distension. Then
Then distant sounds.
very good. Muffled heart sounds. Distant muffled heart sounds. Very good. So this is the classic triad, which is something, I think it's Beck's triad, right?
Yeah.
Yeah.
Yeah, the classic Beck's triad for cardiac tamponade. What is the ECG finding? How does the ECG look for cardiac tamponade?
Is electrical alternance of the QRS complex.
Very good. Electrical alternance. So it actually looks something like this. I mean, this is there. Then, okay, I'm not that good, but anyways, this is there. Then T wave is there. Then again, big normal. Then whatever.
Mm.
Small. So basically, big QRS, small QRS, big QRS, small QRS, alternating. That is what I'm trying to prove. Okay. Very easy ECG. Okay. Alternating. Got it, right, everybody?
Yes.
Yes.
Yeah. Clearly, I'm disrupting the whole rate rhythm concept myself, but yeah. So why is there electrical alternance? Why is there
Because
electrical
there is
alternance?
a blood in the pericardial cavity, so because
Hmm.
the heart is moving,
Very good.
that's the
Yeah,
reason.
there is all this fluid and the heart is just going back and forth. That is why you have this electrical alternating activity, right?
Yes.
Mm.
That is why electrical alternance. Now, something let me ask you a question. Yeah, always remember one thing. We talked about this thing, right? That viral infection is the major cause for dilated cardiomyopathy, Coxsackie virus that we talked, or any recent viral infection. Then pericarditis also the most common cause is recent viral infection. Another important thing is cardiac tamponade, where also there has to be always a recent upper respiratory infection, GI infection, anything. Somewhere in the question, it will be there. Okay, so once you become sure, you want to get double sure, check, go read the question again, and you will see somewhere that last week the patient had runny nose or diarrhea or whatever, something indicating recent viral illness. All right, what will happen if a patient has cardiac tamponade? What will happen to the left ventricular preload? It's that arrow question. Think and tell me. What will
That
happen
will
to the left?
decrease.
Oh wow, very directly. Why would it decrease?
because the septum would be pushing towards the left side, and the cavity size will decrease.
Okay. Huh. Okay. Not exactly, but same mechanism, but more pronounced towards the right heart. Okay. Why the left preload is decreasing? Because like you said, the cardiac tamponade, the blood pushing, like pressing on the heart, so the right side of the heart gets affected more in this kind of situation. The right heart is getting compromised. Right heart, we know, when gets compromised, does not pushes blood forward to the pulmonary system, and no blood coming back to the left heart. That is why the left ventricular preload is decreased.
All right, all right,
Okay, so it
all
mainly
right.
affects the right side of the heart, right side compromised, and hence the left heart is not getting any blood. Got it?
Got
Everybody,
it.
everyone on the
Yes.
same
Yeah.
page? Okay. Now,
Yes.
something new that I came across, and I did a silly mistake because I love to do silly mistakes. That is this question. Um, Now there are two types of cardiac injury. Not types, but
We can't
simply
hear
the.
you. Or I can't. There's a lot
Um,
of noise, right?
Yeah, I can't hear.
Did you
okay.
turn on the fan?
No, no, I did not turn on anything. But I think everybody should just mute themselves. Maybe it's coming from somewhere.
Oh,
Everybody mute, muted.
I still can't hear.
I, even I can hear that thing.
I think it's Vera.
Yes, yes, I can hear.
Yeah, but can you everybody just mute yourselves? Maybe there is some background noise coming. Oh yeah, who was that? Okay, now, see again, silly mistake. So everybody's mute, so nobody can answer. All right, got it. Anyways, so this question is cardiac tamponade can be acute or chronic. Now, it's easy only. When it is acute, means it has started, the leakage has started, but still it is not, the fluid is not, there's not a lot of fluid. In simple words, not a lot of fluid. 100 to 200 ml of fluid is accumulated, whereas in chronic, 1 to 2 liters of fluid has accumulated. Beck's triad is present in both. Signs and symptoms are going to be present in both because it is cardiac tamponade, and everything is same. But acute is in minutes to hours. This one is days to weeks. Now I got this question and I was so silly. I There was Beck's triad, and I really wanted to go for cardiac tamponade. But for people like me, oversmart people like me, they gave one thing in the question, that the X-ray the chest X-ray shows a normal cardiac impression, and according to me, cardiac tamponade has to be enlarged globular heart image, right? So I got tempted to go for something else. I don't even remember what I went for. Something they must have given to confuse me. But anyways, I went for something else, and turns out that the answer was cardiac tamponade, and
Mm.
the answer was acute cardiac tamponade. So remember like this, that in acute case the X-ray can be normal, the cardiac impression can be normal. Here it is enlarged and globular, but acute can be normal because it's still 100 to 200 ml of fluid. Got it? That is the only difference.
Yes.
So if everything is pointing towards cardiac tamponade just based on one finding, don't confuse yourself and go for it.
Okay.
All right, so we are done with that. Yeah, now we are done with all the old things. Hmm. All right, I want to do a few more topics. Okay, again, easy topic, but good amount of questions is pulmonary hypertension. Just have to know one or two basic things about it. There are 5 groups in it. We don't have to focus on all 5. We just need to know group 1 and group 2. Group 1 means the cause is idiopathic, means the problem is actually in pulmonary. vessel. Group 2 means the problem is not in the pulmonary vessel, the problem is in the left side of the heart. And you know, we talked yesterday that this side of the heart, if gets affected, goes back, the pressure goes back to the pulmonary vessels, right? So that is causing pulmonary hypertension. That is group B. 2. 3 means any problems within the lungs like COPD or anything. Group 4 is any thromboembolic situation blocking the pulmonary vessels. Group 5 is hematologic and blah blah blah. Don't need to know that story. The first, the primary, what is the treatment for that? And secondary, what is the treatment? That is high yield. So yeah, any guesses?
Bosenton. Bosenton.
Endothelin
Yes, very good. Endothelin receptor antagonist,
receptor antagonist.
bosentan,
Bosentan.
for primary pulmonary hypertension. Okay, that's very, very high yield. And what is the this treatment for the second left heart problem?
Is it nitric oxide?
Mm, no, not like first line.
AC inhibitors.
ACE inhibitors or loop diuretics, or basically decreasing the load of the heart, because that volume overload is the one that is creating the problem and back pressure and pulmonary hypertension, right? So you
Okay.
want to give diuretics to remove that load, plus you can give ACE inhibitors or ARBs. Some patients you can also give beta blockers, but always stick to diuretics for that, and ACE inhibitors. Okay,
Yes.
clear everyone?
Yeah.
Yes.
Okay, okay.
Yeah.
All right. Okay, there is still how many pages are there? Right. So today I'm just going to revise one chart right now, and then we'll first finish CVS, and at the end, if time permits, then I'll ask you all the random questions from CVS. Sounds good?
Okay.
Okay. So I don't want to I basically I want to get done with CVS first, get that load off, and then we can talk about questions. All right. So
Yes.
before that, let's just quickly brush up one most important chart and then we can go ahead. Tell me about management of a patient coming with tachycardia. Okay, and now first thing is, I'm just starting it. It can be sinus tachycardia, just sinus tachycardia. So for them, you don't have to do any management, just have to treat the underlying cause. Okay, whether it's stress or whatever. No drugs. But if it is not sinus tachycardia, it can. Then what is next? Come on, now you will start. What to check next?
You check if they're hemodynamically stable.
Very good. Then what to do? Like, are they stable, not stable? Then what to do?
If not stable, then you go for cardioversion.
Which one?
A synchronized cardioversion.
Synchronized. Then, if stable, then what?
And then you do an ECG.
Hmm.
You'll check for the QRS.
Superb. What in QRS?
If it's wide or narrow.
Hmm. Okay, if it's wide, then what next?
I'm trying to remember. Then you
No.
check the rhythm.
Okay, you're doing good. Others can also speak up. Rhythm.
Yes, please.
Okay, the rhythm is regular or not, right?
Yeah.
If the rhythm is regular and the QRS is wide, then what is it?
Monomorphic ventricular tachycardia.
Very good. Monomorphic ventricular tachycardia. What is the treatment?
Amiodarone.
Amiodarone.
Amiodarone. Okay. If the rhythm is irregular and wide QRS, then what is it?
Atrial fibrillation with aberrant conduction.
Very good. Yes, yes. AFib with aberrant conduction pathway. I'm so sorry, guys. Just give me a minute. I have to take this call. Okay. Sorry. Hello. Hello. I'm. Oh ho ho. There, તમે તો ખબર ને 2 મહિનામાં પહેલી વાર તમે ફોન કર્યો એમ. કઈ નહીં ક્લાસમાં છું ક્લાસ પતે એટલે કરું તમને કઈ કામ છે અર્જન્ટ ચાલવા ગયેલા અચ્છા હા પણ હું કરું તમને પતે એટલે હા ઓલરાઈટ sorry atrial fibrillation with aberrant conduction pathway. So the management for that would be all the rhythm control agents, procainamide, ibutylate, or anti-arrhythmics. No questions on that. All right. Then QRS narrow. What is it?
If it's regular, it will be an SVT.
Very good. SVT. And what is the treatment?
Adenosine.
Okay.
Carotid massage, pulse alpha maneuvers, all
Very good. Very good. So all the vagal maneuvers and or adenosine. Okay. Very good. And what if it is irregular?
AFib,
Or?
flutter.
Very good. What is the treatment?
Same like rate control or rhythm control. Beta blocker. And
very good. Beta blockers, calcium channel blockers, and if you have to check whether you want to add anticoagulation or not. So for that, you have to calculate the CHA2DS score, right?
yeah, yes.
All right. So let's just go ahead. We stopped on what we did pulmonary hypertension, right? Okay. The valvular conditions remain. Okay. The last thing that we did was the abdominal aortic aneurysm, right? So let's quickly do the next topic, which is about peripheral artery disease and acute limb ischemia. Now, see, there are two conditions. One is venous problem, right? And one is arterial problem. Now, in arterial, you have to decide between two, whether it is peripheral artery disease or acute limb ischemia. So, starting with the difference between whether it's arterial problem or venous problem. Anybody can tell me what are the differentiating clinical features in these two?
In arterial, sorry. In arterial, there would be signs and symptoms of limb ischemia, like pallor, pulselessness, etc.
Okay, very good. Then pallor, paresthesias, pulses, electric activity. Okay, then anything else?
It's acute, like not like peripheral arterial disease, like for a long time. It's an acute onset for the ALI.
Yeah, that is true. That is true. But I'm first differentiating whether it's artery or vein. Okay. So, what are the differentiating features that will tell you that it's an arterial disease or it's a venous disease, venous insufficiency? So
Okay.
you said pain, paresthesias, pulses, activity. That is perfect. That is all for arterial. Then what are the features for venous?
In venous, there would be congestion, like discoloration.
Very good. Very good. Then
Varicose veins.
very good. Okay.
Like heaviness increase like throughout the day,
Okay.
like CVT.
Okay. So the DVT and everything that you guys are saying. So most common features that you see in artery is pain, pallor, paresthesias, pulses, and coolness to touch. They are very cold because again, no blood supply to that area. So that limb is cold. Whereas cold and shiny, if you remember these things. And venous things, most important is the hemosiderin deposition, which is the discoloration of that area, and ulceration. Most common location for the ulceration is what part?
Medial malleolus.
Super. Medial malleolus. Whenever there is a medial malleolus ulcer, think of venous first. Okay? Clear?
Yes.
So these are the most important features that differentiate whether it's venous or arterial. Now, once you are in arterial, then you have to decide whether it's peripheral artery disease or acute limb ischemia. In that, what you said was absolutely right. That Peripheral artery disease. Now, it's a disease that has been going on, building up since a long time. Just like you can say atherosclerosis. This is just atherosclerosis, where the patient is a long-term hypertensive patient, and now slowly, the atherosclerosis is building in the peripheral arteries and coming up with the signs and symptoms of the 6Ps. But if, for example, a patient has these atherosclerosis in, for example, aorta, and a little chunk gets out of it, and that thing throws an embolus, and that embolus lodges in the foot, then the pain is going to be sudden, severe, and these 6Ps. So if it is
Mhm.
sudden onset, it is acute limb ischemia, but it is slowly ongoing, progressing. Since 1 week I have these issues, since a month I have these issues, means it is peripheral artery disease. Okay, only difference is one is acute, one is chronic. That's the main difference, and every time these two are going to be in the option, so don't confuse. Acute limb ischemia, as the word suggests, it is because of an embolus coming and lodging in that place and then causing symptoms, whereas peripheral artery disease is atherosclerosis. All right, so I told you the main cause of peripheral artery disease, atherosclerosis, right? So other risk factors can be what? Patient with diabetes, hypertension, smoking, age more than 70, all these. We also discussed about the clinical features: pain, pulses, paresthesias, cold, bruise, stenosis. Again, all those easy things. But there is one peripheral artery disease which is you if so basically all these blood vessels in the lower limb can be affected. So if the femoral vessels, I mean the pelvic area vessels, get affected, there is a particular syndrome that happens which is called, I don't know how to pronounce it, but maybe it is Lyric or Lerich. I don't know how everybody says it. Lyric syndrome. And there is a classic triad of Lyric syndrome. Anyone knows?
Yes, there will be impotence, erectile dysfunction,
Hmm.
and bilateral claudication.
Okay. So pain because of that claudication, right?
Okay.
So pain in the pelvic area, abnormal pulse, and decreased erectile function. That is Lyric syndrome, which is a part of PAD. Based on that, like every other location, if there is thigh pain, calf pain, all that can be there if that particular area artery is involved. What is the diagnostic test that we use for PAD?
Brachial is it
Very good.
AI arterial brachial index?
Ankle brachial
Ankle
index.
brachial. Ankle.
Yes, right. Ankle brachial index. Do you know the normal values of ankle brachial index?
I think it's between 0.9
Very good.
to 1.1.
1.3. Okay.
Oh, yeah.
0.9 to 1.3. If it is less than 0.9, it's abnormal. If it is more than 1.3, means it is calcified and very, very stiff. Okay.
Mm-hmm.
So anyways,
Mm-hmm.
it should be between 0.9 to 1.3. Haven't seen questions, but still I would suggest that it's good to remember this value. 1 or 2 questions might be there. All right. Then the management. Each and everything is high. Okay. The diagnostic test, management.
Exercise.
Very good. Number one is rigid exercise. You guys think I'm back in a minute.
Okay.
Yeah, sorry. It's just that there are a lot of mosquitoes out here. I have to get my jacket. Okay, perfect. Treatment. Hello. Hello.
Yeah.
Yes.
Oh yeah,
So
thank God. I'm like everybody's gone or what? Okay. Exercise number one. Yes, super. That is very, very high. First is graded exercise. Number two. Any medication that you can think of to start?
Like we give aspirin
Super. Aspirin.
and statin.
And
Statin.
very good. Statin. Then, if this does not help, first plan of action is going to be start with graded exercise, give them aspirin and statin. If that is not working, if this regimen fails, then what to do?
Embolectomy.
Mm, you can go for that, but before that, there is one medication that we would still try.
is it anticoagulation?
Which blood? I mean, which
Heparin?
mhm. Cilostazole. So many times cilostazole is given for, it's a blood thinner. Many times that is given in the options, and you get tempted because this is like usually people go for this. But remember that first would be aspirin statin. If that fails, if that is given in the question that this have been tried and tested and failed, then only pick this answer. Otherwise, don't pick this answer. Okay. And if after cilostazole also it's not working, then you can go for surgical. I mean, with cilostazole, you can go for surgical or percutaneous revascularization. Okay. Now,
Okay.
after trying everything, um, I mean, for example, if a patient is coming to you and the patient has all these gangrene signs and symptoms, yeah, black and yeah, Eshkar is there and everything, and the patient has systemic signs and symptoms like confusion, lethargy, fever, then what to do? The cause is PAD, that is established in the question. Because of that, there is a gangrene and there are systemic signs and symptoms of confusion, basically severe sepsis. What is the next step of management?
Amputation.
Super. So only case where you directly go for amputation without trying any medication is this case where it is gangrene, because now this stage is irreversible and the infection is just going to spread further. Clear?
Yes.
All right. All the MCQs for from PAD clear, right? Everyone followed?
Yes.
Okay, then tell me, if a patient is diagnosed with PAD, that increases the risk of which other condition of this patient?
Am I?
Wow, super. MI, right? Myocardial infarction. Why? Because this is an atherosclerotic disease. If the atherosclerosis has reached the limbs and it has gone to the level of PAD, means the heart vessels are also getting blocked, right? Because atherosclerosis is not selective, it's going to happen everywhere. So that patient is at high risk for MI. Make sense?
Yes.
All right.
Yes.
Okay. Then coming to acute limb ischemia. So acute limb ischemia, all right. Acute limb ischemia. Tell me a few features that you all. Now we know the 6 P's. Okay, we are not discussing that. Most common risk factors for acute limb ischemia would be what? Think and tell me. Easy only.
Like embolism.
Okay, embolism. But because of what? From where did that embolus come? So one I told
Like
you already, atherosclerosis. Then
A AF.
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 okay,
Atrial
very good.
fibrillation.
Yes, atrial fibrillation. Then
Like malignancy.
okay, yeah, that too makes sense. Malignancy. So most commonly, other type of questions can be any catheterization or like subclavian catheter is inserted, or any that I forgot the name of that thing. You insert
Like,
that catheter, no, that transvalvular catheter, which to repair valves in the heart. There is this very thin catheter passed, which goes from the right atrium to the right ventricle. Anyways, that's too much in details. But any procedure, SVC or any cardiac catheterization, any procedure done in the body, that can also trigger and release this embolus. So most commonly, cardiac catheterization due to XYZ reason would be given in the question. All right. Then the 6 P's. What is the treatment of acute limb ischemia?
anticoagulant, like we'll give IV heparin immediately.
Very good. Superb. IV heparin immediately. Okay. That's a mainstay.
So we don't like do a transthoracic first, echo.
Yeah. We will
Like,
do transthoracic echo as well to rule out and check any cardiac condition or any vegetation on the heart valves. But first heparin, then transthoracic echo.
and what about like Doppler ultrasound? We don't check. No need. Like we
That is
start first.
good point. Transthoracic, whatever Doppler. So now you tell me, where do you do that? Do you do it for arterial condition or venous condition?
Venous.
Venous, right? Doppler USG for the limb is done for venous conditions. For arterial conditions, ankle brachial index is done. Okay.
Oh, yes.
This in this one, acute limb ischemia, we do transthoracic echo just to rule out any cardiac condition, valvular conditions, like anything related to cardiac, because that is the most common risk factor, right? But that's again second line. First is always IV heparin. Everybody clear, right?
Yes.
Okay. One more kind of similar topic is cholesterol crystal embolism. This is the most easy one because the typical findings that you see in cholesterol crystal embolism is not seen anywhere else. Anybody knows a few clinical presentation?
The skin manifestation, the lazy skin rash.
Okay.
Uh,
Lacy skin discoloration. It's called something if you know. What is this condition called? This lacy skin rash? Reticular lacy skin discoloration is called livedo reticularis, right?
yes. Yes.
But you are right, they are not going to give you livedo reticularis in the question, right? They'll give lacy skin discoloration or reticular skin discoloration or erythema that blanches on pressure, all those things. Anyways, just remember any skin condition. Then what else? One more typical thing, one more dermatologic thing for cholesterol question. Blue toe syndrome. Okay, blue toe. Always remember blue toe. If they say that there is discoloration of the toe, skin discoloration, think of cholesterol crystal embolism. And most common risk factor is going to be again cardiac catheterization, right? Any procedure you do, that is going to that's going to be the risk factor. Any vascular or cardiac procedure, risk factor for releasing this cholesterol embolus. So after a patient undergoing cardiac catheterization or any vascular position and then coming to you with skin discolorations, that is cholesterol crystal embolism. Another very high yield clinical feature is the renal, acute or subacute kidney injury, AKI. Now the question is, after cardiac catheterization, if a patient is coming to you, okay, and now they are not giving all these things, but they are just focusing on the renal part of it. The BU and create ratio is disturbed and everything. You might get confused between two things. One thing that should come to your mind is cholesterol crystal embolism. What is the other thing that should come to your mind as the risk factor for AKI?
The contrast induced.
Very good. Super. Contrast induced. So how will you differentiate between these two?
like the timing for
Very
this
good.
one. uh, it will start after like 2 to 3 days and it will last for up to 2 weeks.
Okay.
While for the contrast induced, like it will start like within hours and it will be relieved within like 2 to 3 days.
Very good. Superb. So cholesterol crystal embolism is going to persist for more than 2 weeks, whereas contrast induced AKI is going to resolve in 2 to 3 days, not more than a week. Usually 2 to 3 days. All right. So they can give you a confusing question where you get tempted with both cholesterol crystal as well as contrast induced. Just look at the timeline. 2 to 3 days, that is contrast induced. More than 2 weeks, that is cholesterol crystal induced. All right.
Yes.
Perfect. And treatment would be what?
Supportive.
Very good. Supportive. You can sometimes give statin therapy, but the main thing is just treat like whatever underlying, not that, but lifestyle modifications, like if the person is smoker, stop smoking, obesity, all those things. Okay.
Mm.
Clear with this up till now?
Like, do
Yeah.
we give IV
Yeah.
fluid?
Sorry, can we get what?
IV fluid or no?
Yeah. Fluids, of course, of course. Fluids is there only.
Okay.
All the supportive things. Yeah, all the
Yes.
supportive.
Okay.
Oh, yeah, and one more thing. Sorry, in the labs, for the labs, something peculiar for cholesterol crystal embolism is one more thing. That is eosinophiluria. Okay, eosinophilia, and in urine, eosinophiluria. So basically, there is going to be eosinophils. Sorry. Okay, got it.
Yes.
I won't take it for now. Let's do a few topics here and there. Okay, so talking about renovascular disease, right? This is not working. You guys can hear me, right? But
Yes.
Yeah.
yes. Okay, let's just discuss these small topics, and then we'll just be left with shock. So, talk about renal artery stenosis. Let's differentiate between renal artery stenosis and fibromuscular dysplasia. Come on, anyone?
In
What age group? Hmm?
dysplasia will be in less than 50 or
Okay. Any So, okay, let me tell you. Renal artery stenosis, most commonly seen in old age. Fibromuscular, most commonly seen in young. High yield point, renal artery stenosis, seen 99.99% times only in males. Fibromuscular dysplasia, 100% seen in
mm,
female. Okay. So, F for fibromuscular, F for females. The situation is the same. It is both because of that the wall problem, atherosclerosis, but renal artery stenosis seen in males, fibromuscular seen in females, younger females, and another vessel involved in fibromuscular dysplasia is what other than renal artery? Any guesses?
carotid.
Superb. Carotid. Very
Mm,
good. Carotid. Because I have seen questions where they have given this pre-auricular or somewhere like in the neck bruit. So
mm.
that's an indication of carotid artery fibromuscular dysplasia. Okay, that's female. Then tell me, what is this condition where mm, young patient is coming to you, 30-year-old, 40-year-old. Okay, and she's saying that there's some kind of there is hypertension. First of all, brand new hypertension that you have seen. There are palpable abdominal masses, and you did the urine analysis. There is proteinuria. What is this?
Polycystic kidney disease.
Very good. So always palpable bilateral abdominal masses and hypertension. It's PCKD. Okay. Always PCKD. What is the diagnostic test?
Abdominal ultrasound.
Very good. That is also UVOL, ultrasonography. Right? Simple. What is the treatment?
Beta blockers.
Mm-hmm. I told you, whenever you see hypertension, just have to give four drugs, right? So
Oh,
here also the answer is ACE inhibitors or ARBs or CCBs. Okay, but
okay.
ACE inhibitors. The main thing for ADPKD is that you just can control the hypertension. You cannot now the masses are there. You cannot remove them. You just have to manage it. Okay, by reducing the hypertension.
Mm.
Then so yeah, that is going to be ADPKD. Then, what is a classic feature of coarctation of aorta? Presentation.
So the blood pressure in the limbs is lower than the arm.
Very good. Very good. Very good. Decreased perfusion to lower extremities, right? That is classic thing about coarctation of aorta. So, discrepancy, blood pressure discrepancy in upper and lower limb. That is this. Yeah. Because of this aortic coarctation, there can be notching of the ribs because of these enlarged intercostal arteries. Okay, so that can be given in the question sometimes, notching of the ribs.
Mm.
Yeah, what condition are associated with coarctation? Which patient category you see this? Any conditions that you know? Congenital? Any congenital condition?
Is it Turner syndrome?
Yes, very good. Turner syndrome. Then what else?
Marfan?
Not Marfan actually. It's Turner's only. Okay. Yeah, it's Turner's majorly, and other things associated can be bicuspid aortic valve and VSD. But otherwise, like situation wise, it's Turner's.
Mm.
Okay. Then three high yield toxicities. Now this is also very important. What are the signs and symptoms of digoxin toxicity? Or digoxin, whatever you say. Anyone knows digoxin toxicity?
There will be nausea, vomiting,
Very good.
pain,
Visual changes.
Very good.
color changes.
Very good. So
Uh,
So I remember like this when there is multi-system involvement, GI, neuro, and cardio. Three things. Okay. Nausea, vomiting, abdominal pain, GI. Neuro, fatigue, confusion, color vision changes that you said, high yield. And a cardiac because arrhythmias, life-threatening arrhythmias, right?
mm.
That is digoxin toxicity. Then tell me a few things about amiodarone toxicity. Before starting amiodarone, you do a lot of tests, if you remember from step one.
You should
Thyroid
check
function.
thyroid function,
Very
Yeah.
good.
T,
liver function.
Very good.
pulmonary function test.
Super pulmonary function test. So important are these that you said: liver function test, chest X-ray, or pulmonary function test, and thyroid. These are the baseline things that you have to do. That is high. Then other problems can be blue-gray skin discoloration, peripheral neuropathy, and all those things. But important is the screenings that you have to do. And last and most important is beta blocker toxicity. What is the presentation?
Hypotension,
Very good.
bradycardia, and
Mm-hmm.
spasm.
Very good. Bronchospasm, so V's and everything can be there. Bradycardia, hypotension, so syncope can be there. AV block can be there, right? Because you are blocking the beta, so you are decreasing the contractility. You are slowing the entire heart, right? What is the management? What is the first line thing to reverse it?
IV glucagon.
Yes.
Very good. IV glucagon is given, but something before that is also given. First line. What is the treatment for bradycardia?
Oh,
Atropine.
that's great.
Atropine, right?
Yeah.
So this is a trick question. They give both in the options, glucagon and atropine. So remember, first atropine has to be given to reverse the bradycardia, get back normal, and then reversal of beta blocker is done by glucagon. Okay, both are given, but first atropine. So sometimes in the question they already write that atropine is given, then what next to do? Answer is glucagon. But if that is not given and options has atropine, then first atropine. Okay.
Okay.
Glucagon is also used for the reversal of calcium channel blocker toxicity. Okay, remember that also. Okay, then shock is there. Shock. Question. Ha, easy one. Like cardiac myxoma. Easy, right? It's a tumor in which side of the heart?
Left atrium.
Very good, left atrium. So what can be the clinical features?
Syncope. Dyspnea.
Very good. Fever, weight loss, right? It can cause embolization, lung invasion, all those things. Question is, what is the diagnostic test? Now, cardio, I don't know why they asked this question. Answer is
Echo.
Echo.
echo. Echo. Now, if they have given two options in this, there is transesophageal echo and transthoracic echo. What would you do? What would you do?
Transesophageal, I guess.
Yeah. So whenever you have to check any valve or like look at the heart more closely, and in echo you have two options, and transesophageal echo is preferred. Okay, always.
Mm.
Whoosh. That is it. Now only shock is remaining. These are the important points. Let me just quickly scan everything. Oh, one more thing is I missed out. We did peripheral artery disease. We did acute limb ischemia. We did venous valve insufficiency as well, but we missed out on the treatment of venous valve insufficiency. What is the treatment?
Sclerotherapy.
Like elevation.
Leg elevation, exercise, and compression stockings.
Chin stockings, yes.
Yes. And the diagnostic test was what?
Doppler ultrasound.
Very good. Doppler ultrasound. And remember, if one of the option is smoking cessation, so for venous problem, smoking has no connection. Arterial problem, smoke cessation is the answer. But venous has no connection with smoke cessation, so don't go for that option. Okay?
Okay.
Okay.
Okay. And I know you guys are exhausted, and, and it is a lot, but you did great. Just one last thing is compartment syndrome. Similar topic. So, what are the classic findings of compartment syndrome?
Pain out of proportion.
Very good.
Stiff leg, is it?
Very
Hard.
good.
uh,
Yes.
Pain with movements.
Pain with movement. Okay. Very good. Paresthesias or decreased pulses. Rare, but it can be there. Okay. Decreased distal
Yeah.
pulses. But pain out of proportion is like high. Oh, God. Good. Oh my God. We survived. We
Yes.
survived cardio.
Yes.
Great. Great, great, great. All right. So only shock is there. It's very easy. We'll finish it very quickly in 10 minutes tomorrow. All right. And what do we want to start with? Gynec?
Yes. Can we do obs?
Whatever you guys want. I'm good with obs too. I love gynec and obs both.
Yes.
Can we do neuro? Or can we do neuro after that?
Or we
Eh,
can
I
actually
don't.
see what we can do is obs and gynec together will be a lot, similar field. So we
Hmm.
can put in neuro in between and then do gynec.
Okay.
Okay.
Because neuro is very small, it's very easy, not like step one. I don't know, I've seen this with every batch. Everybody's scared of neuro or what? Everybody wants to do neuro first. But it's not like step one. Trust me, there is Nothing like step one. Step two, neuro is just so simple. They are going to ask about dementias. There are going to be four, 5 questions, all on dementias or head trauma, and it's very easy. Neuro, in fact, I finish it the fastest. It's maybe it will take 2 days, not more than that.
Mm-hmm.
So let's keep a break of neuro in between obs and gynec.
That's
Okay. Yeah,
Okay.
that's
good. Yes, thank you so much.
All right.
thank
See you
you.
tomorrow.
Bye.
See you.
Bye bye.
Bye.
Bye.